Post-traumatic stress disorder entails an extreme response to a severe stressor, including increased anxiety, avoidance of stimuli associated with the trauma, and symptoms of increased arousal. Although people have known for many years that the stresses of combat can have a powerful adverse effect on soldiers, the aftermath of the Vietnam War spurred the development of this diagnosis. Diagnoses of these disorders are considered only in the context of serious traumas. The person must have experienced or witnessed an event that involved actual or threatened death, serious injury, or sexual violation. War veterans have often been exposed to these sorts of severe traumas. For women, rape is the most common type of trauma preceding PTSD, with at least one-third of women meeting criteria for PTSD after a rape. Survivors of natural disasters are at risk for PTSD, but their risk may not be as high as those who experience traumas caused by humans, such as in assaults. Once PTSD develops, symptoms are relatively chronic. In one study of people diagnosed with PTSD, about half continued to experience diagnosable symptoms when interviewed several years later. Suicidal thoughts are common among people with PTSD, as are incidents of non-suicidal self-injury. The acute stress disorder diagnosis is not as well accepted as the PTSD diagnosis. There are two major concerns about this diagnosis. First, some have criticized this diagnosis because it could stigmatize short-term reactions to serious traumas, even though these are quite common. For example, after a rape, most women report at least some symptoms. And among people who have been exposed to a mass shooting, about a third develop symptoms of acute stress disorder. The second concern is that most people who go on to meet diagnostic criteria for PTSD do not experience acute stress disorder in the first month after the trauma. As the DSM-5 criteria are so much more parallel with the PTSD criteria, one might expect that the DSM-5 acute stress disorder diagnosis will be predictive of PTSD. The diagnostic category of adjustment disorder made its first appearance in the DSM-3 in 1968, replacing the previous transient situational disturbance of DSM-2. It has persisted into the current version of the DSM. The inclusion of adjustment disorder recognizes that people can often develop symptoms or exhibit behaviors in response to stressful events that are in excess of normal reactions. Resolution with the minimum of intervention apart from general supportive measures is frequent, either when the stressor is removed or as new levels of adjustment adaptation are reached. The trauma-related disorders include post-traumatic stress disorder and acute stress disorder, two conditions that are triggered by exposure to severely traumatic events. The trauma-related disorders were listed in the anxiety disorders chapter of the DSM-4-TR. However, these disorders also have some distinct causes compared to other anxiety disorders.
So a separate category was created in the DSM-5 related to trauma and stress. And one of the diagnoses we'll look at is post-traumatic stress disorder. When we hear PTSD, we often think of our veterans. Prevalence rates for military PTSD are fuzzy. Do you look at PTSD diagnosed within a year of returning from battle? Or do you only count PTSD that limits a soldier's ability to go back into battle or to remain employed, but may have destroyed a marriage or wrecked a family? Also, it is possible to have undiagnosed PTSD for 30 years and not realize it, as symptoms can range in severity. Veterans' PTSD statistics get revised over time. The National Vietnam Veterans Readjustment Study in the 1980s found 15% of men had PTSD at the time of the study. and 30% had PTSD at some point in their life. A more recent reanalysis found many more. 4 out of 5 Vietnam veterans struggled with chronic PTSD symptoms long after returning home. Among veterans using VA hospitals, PTSD is the third most prevalent diagnosis. PTSD is often comorbid with substance use disorders. This comorbidity leads to a worse prognosis for both disorders. A comprehensive analysis published by RAND Corporation found rates of 8% among male and female soldiers returning from Iraq shortly after deployment. And it went up from 8% to 31% a year after deployment. About 19% of veterans may have TBI, traumatic brain injury, which complicates treatment and recovery. The best estimates we have now for military PTSD are from 9% to 31%. Now, trauma and stress can come in many forms. A natural disaster, combat and war, sexual assault, or a serious car accident, for example. In times of peace, in any given year, about 4% of the general population have PTSD caused by what I just mentioned, natural disasters, car accidents, abuse, etc. And most people exposed to trauma don't experience PTSD. Here, we'll take a look at 3 types of disorders in this category. These disorders involve exposure to a traumatic or stressful event, and they are described explicitly in the diagnostic criteria. We'll look at adjustment disorder, acute stress disorder, and post-traumatic stress disorder. What differentiates these disorders is timing and the symptom profile. For adjustment disorders, the symptoms start within 3 months of the identified stressor and last no longer than 6 months after the stressor or its consequences have ended. There is a change from the person's previous emotional functioning and significant impairment. There can be anxiety or depression, making it difficult to work or perform at school. These stressors can include relationship problems, but there's always an identifiable stressor. Trauma-related disorders are acute stress disorder and post-traumatic stress disorder. These 2 diagnoses require exposure, either direct or indirect, to a traumatic event. The diagnostic criteria for these 2 are similar. Acute stress disorder requires symptoms for at least 3 days, but no longer than 1 month. If the symptoms persist for more than 1 month, the diagnosis may be changed to post-traumatic stress. Adjustment disorders involve difficulty coping with or adjusting to a specific life stressor, and the DSM-5 has specific diagnostic criteria. There needs to be exposure to an identifiable stressor that results in onset of symptoms. Now, this exposure is different from the exposure to a traumatic event, which is required for acute stress disorder and post-traumatic stress disorder. The symptoms are out of proportion to the severity of the stressor. It's not always easy to distinguish between a normal reaction and an adjustment disorder, but the reaction is usually intense, and there is a significant change in the person's ability to function. Normal bereavement over the death of a loved one is excluded from these criteria. The symptoms persist no longer than 6 months after exposure to the stressor has ended. Adjustment disorders are associated with an increased risk of suicide attempts and completed suicides. Adjustment disorders are common. In outpatient mental health settings, the principal diagnosis of an adjustment disorder has been as high as 20% of the clients being seen. Adjustment disorders can accompany most mental disorders and any medical condition. For example, someone may have difficulty adjusting to being diagnosed with a serious medical condition, such as cancer.
A diagnosis of adjustment disorder raises a number of dilemmas. The first is the distinction from normal reactions to stress. a separation that is important so as not to pathologize the day-to-day travails of life. The second dilemma is the differentiation of adjustment disorder from other disorders such as generalized anxiety disorder and major depressive disorder. Simply on the basis of symptom numbers and duration of more than 2 weeks, adjustment disorder would be relabeled as major depressive disorder after the time threshold has been crossed, even though the onset of symptoms was temporally close to the stressor. Thus, a young woman with children who had received a diagnosis of stage 4 cancer 3 weeks earlier and now has low mood, is not sleeping, is unable to get pleasure from life, has recurrent thoughts of dying, and has poor concentration, might variously be thought to be experiencing an appropriate reaction, an adjustment disorder, or major depressive disorder. Examples such as this highlight the need for continued monitoring. Ordinarily, one would expect the symptoms to resolve when the stressor diminished or was removed. At other times, notwithstanding the persistence of the stressor or its ramifications, the person with adjustment disorder adapts. A diagnostic conundrum arises, however, when the symptoms and the stressor persist in tandem. Is the appropriate diagnosis chronic adjustment disorder, major depressive disorder, or appropriate sadness? In general, normal reactions to events resolve quickly and do not persist, hence the time frames specified in the DSM-5.
Clinicians seem to love this diagnosis, probably because it suggests that there's a clear cause and effect etiology. But researchers know that etiology is very complex. The recent diagnostic changes have broadened the description to include only hearing about trauma. And this may expand the prevalence of acute stress disorder and post-traumatic stress disorder. Let's take a look at the biological dimension. A traumatic experience is an external event, and hence it does not have a biological causality per se. However, researchers propose that traumatic experiences have an impact on the brain by leaving it hypersensitive to possible danger in the future. There is a brief video in this unit explaining this change in brain functioning. Changes in the hippocampus, the brain structure responsible for memory, leave people unable to distinguish harmless situations, such as seeing fireworks exploding, from ones in which real trauma occurred, such as in combat. The hippocampus may shrink due to overexposure to neurotransmitters and to stress hormones. Another explanation involves the body systems that people have. These systems, like the HPA axis, are designed for homeostasis, which allows us to recover quickly from a threat. Some people are simply more physiologically reactive to stressors, so they would be more susceptible to these disorders. In the psychological dimension, some risk factors have been identified. Pre-existing conditions such as anxiety and depression, hostility, and anger leave someone more vulnerable to developing these disorders, and specific cognitive styles or dysfunctional thoughts, such as a tendency to interpret stressors in a catastrophic manner or to awfulize stressors, can leave one more susceptible because we know there is a mind-body connection. And these cognitive reactions, which may exaggerate stressors, can overactivate the homeostatic systems. And we do know about survivors' guilt, where PTSD sufferers experience guilt about having lived through a traumatic event or about things they had to do to survive. Some trauma results in increased risk for developing these disorders. Some of those factors associated with increased risk include more severe physical injuries, stroke or injury to the head, traumatic brain injury or TBI, which I mentioned earlier, may be part of the clinical picture if there is head trauma involved. There can be post-concussive symptoms such as headaches, dizziness, concentration problems, and even depressive symptoms. I recall experiencing some of these post-concussive symptoms following a serious car accident about 10 years ago, and it took a while to recover, and I still don't have complete memory of that accident. Symptoms of TBI can overlap with symptoms of ASD and PTSD, so medical evaluation is an important consideration, and you may even need to get a neurological evaluation. Some other factors include major burn injuries, rape or sexual assault, intentional or self-inflicted trauma, and finally, a close relationship with the perpetrator of sexual assault leads to a significantly increased risk of developing these disorders. For acute stress disorder, at least 9 symptoms from across these symptom clusters must be present from 3 days to 1 month after exposure. For PTSD, 1 or 2 symptoms from each of these groups must be present for at least 1 month. I'll briefly describe the symptoms of each cluster for you. The first group, intrusion symptoms. These may include recurrent intrusive memories or recurrent distressing dreams and nightmares. There may be dissociative reactions such as flashbacks. People may have symptoms of depersonalization or derealization, as I described in Unit 3. There may be extreme physiological reactions to cues that remind someone of the event, such as hearing a loud bang taking someone back to the combat field. The next group includes avoidance symptoms. This refers to persistent avoidance of things that remind someone of the event or avoidance of things that are closely related to the event, such as people, places, and even avoiding conversations about the event. The next cluster of symptoms involves negative alterations in mood or cognition, which include the inability to remember important aspects of what happened. This is dissociative amnesia, as we discussed in the last unit. This amnesia, though, is not due to head injury or alcohol or other drugs. There may be negative views of oneself, others, or the world. Someone may think and say, "I am terrible," or "no one can be trusted." The person may blame himself or herself. They may experience survivor's guilt. And there is overall a negative emotional state, and the person may be unable to feel happy. The final group of symptoms are the arousal symptoms and changes in reactivity. The person may be irritable or engage in reckless or destructive behavior, blowing up at the slightest provocation. They may have trouble sleeping. Hypervigilance is a common symptom in this group. This is where the person is constantly on guard. Heightened arousal can be seen in an exaggerated startle response, where the person jumps at the slightest noise or has difficulty concentrating. In order to diagnose an acute or post-traumatic stress disorder, the DSM-5 has certain requirements. The first one is exposure to a traumatic event. And trauma is described as death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. One question to consider as we go through this chapter: is it enough to be considered a trauma if you are a bystander or a distant observer? For example, can you be traumatized by watching a terrorist attack on TV? Well, the DSM-5 has some specifics in terms of ways people can be exposed to trauma. The first one is directly experiencing the traumatic event or events. The second one is witnessing in person the event as it occurs to others. The third, learning that the event occurred to a close family member or a close friend. The event must have been violent or accidental. And finally, experience repeated or extreme exposure to aversive details of the traumatic event. And this applies to repeated exposure by first responders, for example. The DSM-5 says exposure does not include electronic media, television, movies, or pictures unless it is work-related, such as homicide detectives who see photographs of crime scenes all day. And the DSM-5 definition no longer requires people to feel traumatized at first exposure. In other words, the symptoms can have a gradual or delayed onset. Let's review some of the treatments for trauma-related disorders. Certain antidepressants show some effect. The thought is to desensitize the physiological fear response. They are effective in fewer than 60% of cases, though. SSRI antidepressants are the only FDA-approved medications for people with PTSD. Generally, cognitive behavioral therapy involving some type of exposure, in vivo, live, or imaginal, combined with relaxation and cognitive restructuring, is considered the most effective psychological treatment. Prolonged exposure therapy is showing positive results. These therapies focus on extinguishing the fear of the trauma-related stimuli. Now, prolonged exposure therapy is preferred among military personnel, and there is a video discussing this treatment modality in this unit. In eye movement desensitization reprocessing, EMDR, the client is asked to think about a traumatic memory while focusing on rapid movement of the clinician's finger for about 10 to 12 eye movements. EMDR is being increasingly used, but there's still uncertainty about its effectiveness. And positive psychology is offering the proposal that people can grow through the experience of trauma. Therapists help clients find positive interpretations of their experience. I'm reminded of Viktor Frankl, a Holocaust survivor, who developed an existential approach. As a survivor of a concentration camp, he observed that who a person became was not due to camp influences alone, but rather a result of finding meaning and purpose in what you went through.